Many of the modifications made in cortisol-related drugs are specifically designed to reduce mineralocorticoid receptor activation while preserving and enhancing glucocorticoid receptor signaling. This slide shows a series of cortisol-based drugs, all derived from the same steroid scaffold but modified to achieve different therapeutic goals. We'll start with hydrocortisone, or cortisol. Hydrocortisone represents the natural baseline, moderate glucocorticoid activity, some mineralocorticoid effects, and a relatively short duration of activation. Moving to cortisone, we see a closely related compound that differs primarily in oxidation state at the 11 position. Cortisone itself is less active and must be converted to cortisol in the body. This reinforces how small functional group changes can strongly influence biological activity and metabolism. Prednisone is another example of this principle. It's a prodrug that's converted in vivo to prednisolone, increasing glucocorticoid potency while reducing mineralocorticoid activity compared to cortisol. This makes prednisone particularly useful for systemic anti-inflammatory therapy. Fludrocortisone introduces fluorination, which dramatically enhances potency, especially mineralocorticoid activity. Clinically, this drug is used when sodium retention and blood pressure support are desired, rather than anti-inflammatory effects alone. Triamcinolone, dexamethasone, and betamethasone illustrate how additional substitutions, including fluorination and modifications at carbon-16, further increase glucocorticoid selectivity while minimizing mineralocorticoid effects. These compounds are significantly more potent than cortisol and have longer duration of action. Aldosterone, shown here as a hemiacetal derivative, serves as an important contrast. Although it shares the steroid scaffold, it functions primarily as a natural mineralocorticoid in the body, reinforcing the idea that receptor selectivity arises from subtle but strategically placed structural differences. The key takeaway is that all of these drugs originate from the same core structure. Medicinal chemists exploit small, targeted modifications to tune potency, selectivity, duration of action, and clinical use. For our purposes, prednisone and dexamethasone are the most clinically relevant examples to focus on. Let's take a look at two very commonly used glucocorticoids and see how all of this chemistry plays out in real clinical drugs. This slide focuses on prednisone, one of the most commonly prescribed systemic glucocorticoids, and it highlights an important concept. Prednisone is a prodrug. On the left, you see prednisone in its administered form. Structurally, it differs from active glucocorticoids at a critical position, the 11 position, on the steroid scaffold. Instead of an 11-beta hydroxyl group, prednisone contains a carbonyl, shown here in red. Because of this, prednisone itself does not effectively bind to the glucocorticoid receptor and is considered pharmacologically inactive. After administration, prednisone is converted in the liver by 11-beta HSD1. This enzyme reduces the carbonyl group to the 11-beta hydroxyl group, producing prednisolone, shown on the right. That hydroxyl group is essential for glucocorticoid receptor binding and activity. Prednisolone is the active form and binds the glucocorticoid receptor much more strongly than the mineralocorticoid receptor, which helps reduce unwanted electrolyte effects compared to cortisol. This enzymatic activation step allows prednisone to function as a controllable, systematically regulated glucocorticoid. Importantly, this also ties back to tissue-specific regulation. In the kidney and placenta, or a different enzyme, 11-beta HSD2, converts active glucocorticoids back into inactive forms. This protects mineralocorticoid receptors from being overstimulated by glucocorticoids and helps maintain proper electrolyte balance. The key takeaway from this slide is that prednisone's clinical behavior is not just about receptor binding, it's about enzyme dependence, tissue specificity, and metabolic control. Prednisone works within the body's regulatory systems, which is one reason it's widely used for chronic inflammatory and autoimmune conditions. This slide illustrates why prednisone is commonly used during acute asthma exacerbations. In asthma, the airway becomes narrowed, not just from smooth muscle constriction, but from inflammation, edema, and mucus production. Prednisone targets this inflammatory component by activating glucocorticoid receptors and suppressing pro-inflammatory gene expression. Over hours to days, this reduces immune cell recruitment, decreases cytokine production, and helps restore airway diameter. That's why prednisone is often prescribed as a short oral course during asthma flares when inhaled therapies aren't sufficient. Because prednisone replaces normal cortisol signaling throughout the body, it must be taken exactly as prescribed. Stopping it abruptly can have serious consequences, which we'll look at on the next slide. This slide explains why it's critical to taper systemic glucocorticoids like prednisone rather than stopping them abruptly. Under normal conditions, cortisol production is regulated by the hypothalamic pituitary adrenal axis, or HPA axis. The hypothalamus releases the corticotropin-releasing hormones, as we've seen, which stimulates the anterior pituitary to release ACTH. ACTH then signals the adrenal cortex to produce and release cortisol. Cortisol feedback negatively inhibits both the hypothalamus and the pituitary, suppressing further CRH and ACTH release. This negative feedback loop keeps cortisol levels tightly controlled. When a patient takes prednisone, the body interprets this exogenous glucocorticoid as cortisol. As a result, CRH and ACTH levels decrease, and the adrenal glands reduce their own cortisol production. Over time, this can lead to adrenal suppression or even adrenal atrophy. If prednisone is stopped abruptly, the suppressed adrenal glands cannot immediately resume adequate cortisol production. This can result in acute adrenal insufficiency with symptoms such as fatigue, weakness, hypotension, hypoglycemia, and in severe cases, adrenal crisis. Tapering the dose allows the HPA axis to gradually recover. As the external steroid dose is reduced, CRH and ACTH signaling resumes, giving the adrenal glands time to restore endogenous cortisol production safely. In short, tapering isn't about the drug leaving the body, it's about giving the endocrine system time to turn back on. This slide highlights some of the common side effects patients may experience while taking systemic glucocorticoids like prednisone. Importantly, these effects are not random. They follow directly from how glucocorticoids act in the body. One commonly reported effect is increased appetite. As we discussed earlier, glucocorticoids signal a metabolic stress state. They promote gluconeogenesis and increase circulating glucose. And in the brain, this is interpreted as a need for energy intake. As a result, many patients feel significantly hungrier than usual while on prednisone. Mood changes are another well-known effect. Glucocorticoid receptors are widely expressed in the central nervous system, and altering their signaling can affect neurotransmission. Patients may report irritability, anxiety, difficulty sleeping, or mood swings. In some cases, especially at higher doses, more pronounced psychiatric effects can occur. Changes in appearance, such as facial fullness or acne, can also occur. These effects reflect altered fat distribution, fluid retention, and effects on skin integrity, again tied to glucocorticoid regulation of metabolism and electrolyte balance. Visual symptoms, such as blurred vision or eye discomfort, can also occur, particularly with long-term use due to changes in intraocular pressure and glucose handling in ocular tissues. The key point is that these side effects arise because prednisone is not a targeted drug. It is a systemic hormone mimic. While this broad activity makes it extremely effective at controlling inflammation, it also means that many tissues respond simultaneously. This is why dose, duration, and tapering are so important in clinical use. So far, we've focused on prednisone as a commonly prescribed glucocorticoid that balances effectiveness with manageability. Now let's look at a very different end of the spectrum, dexamethasone, a synthetic glucocorticoid designed for maximal potency and minimal mineralocorticoid activity. Dexamethasone is one of the most potent synthetic glucocorticoids in clinical use. Structurally, it's still built on the same cortisone scaffold, but key modifications dramatically change its pharmacological profile. Compared to prednisone or prednisolone, dexamethasone contains a fluorine substituent and additional structural features that significantly increase glucocorticoid receptor affinity while almost completely eliminating mineralocorticoid activity. This means it produces powerful anti-inflammatory and immunosuppressive effects without promoting sodium and water retention. Clinically, this makes dexamethasone useful in situations where strong, sustained glucocorticoid signaling is required, such as cerebral edema, severe inflammatory conditions, chemotherapy-associated nausea, or specific endocrine suppression tests. However, this increased potency comes with very important consequences. Dexamethasone has a longer half-life and stronger suppression of the HPA axis than prednisone. As a result, even relatively short courses can significantly suppress endogenous cortisol production. This reinforces the important theme in medicinal chemistry. Increasing potency is not inherently beneficial. Structural modifications that enhance receptor binding also amplify systemic effects, endocrine disruption, and the need for careful dosing and tapering strategies. When comparing prednisone and dexamethasone, we're not just comparing two drugs. We're seeing how small chemical changes can shift a molecule from a flexible, commonly used therapy to a highly specialized, high-impact intervention. Dexamethasone is not a stronger prednisone. It's a different tool entirely. It's used when we want maximum glucocorticoid effect with minimal mineralocorticoid activity and longer duration of action. Here's a real-world case where all of this chemistry mattered. This figure summarizes why dexamethasone became a life-saving therapy in severe COVID-19, but not in mild disease. In patients with advanced disease, the dominant problem is no longer viral replication, it's immune-driven inflammation, particularly from monocytes. These cells enter a highly pro-inflammatory state that contributes to lung damage and respiratory failure. What this study shows is that dexamethasone shifts monocytes out of that pro-inflammatory state into what the authors call a DEXA response state. In this state, inflammatory gene expression is suppressed, antigen presentation markers like HLA-DR recover, and immune signaling becomes more regulated rather than chaotic. Importantly, this is not global immune shutdown. Patients who respond to dexamethasone showed selective immunomodulation, not complete immunosuppression. This helps explain two key clinical observations: why dexamethasone improves survival in severe COVID-19, and why it does not benefit and can even harm patients with mild disease. From a medicinal chemistry perspective, this is a powerful example of how potent glucocorticoid signaling sustained over time can be therapeutic when inflammation itself becomes the disease. This slide directly compares prednisone and dexamethasone and helps explain why clinicians choose one over the other in different situations. Although both drugs act through the glucocorticoid receptor, they behave very differently in the body. Starting at the top, prednisone is a prodrug. It must be converted in the liver by the 11-beta hydroxysteroid dehydrogenase type 1 enzyme into prednisolone to become active. This means its effectiveness depends on metabolic activation, which can vary between patients and clinical contexts. In contrast, dexamethasone is not a prodrug. It is active as administered and does not rely on enzymatic conversion. This difference shows up clearly in enzyme dependence. Prednisone has high dependence on 11-beta HSD1, while dexamethasone has minimal dependence, making its pharmacological effects more predictable. When we look at the glucocorticoid receptor potency, prednisone has moderate GR potency, whereas dexamethasone is very potent. Small doses of dexamethasone produce strong and sustained glucocorticoid effects, which is why it's often used in severe or life-threatening inflammatory conditions. Mineralocorticoid activity is another key distinction. Prednisone retains low but measurable mineralocorticoid receptor activity, which can contribute to fluid retention and electrolyte effects. Dexamethasone, on the other hand, has minimal mineralocorticoid receptor activity, making it less likely to cause sodium retention or edema. Duration of action further separates these drugs. Prednisone has a short to moderate duration, which allows for dose adjustment and tapering. Dexamethasone has a much longer duration of activation, leading to prolonged receptor activation and stronger suppression of endogenous cortisol production. All of these factors feed into the overall clinical philosophy. Prednisone is used when clinicians want a flexible, adjustable, systematic steroid, especially for outpatient or chronic use. Dexamethasone is chosen when a potent, sustained anti-inflammatory effect is needed, such as in severe COVID-19, cerebral edema, or oncological settings. The key message from this table is that drugs are not interchangeable. Their chemical modifications translate directly into differences in metabolism, receptor selectivity, duration, and clinical strategy, which is exactly what medicinal chemists aim to achieve. This slide highlights an important idea that often gets overlooked when we think about glucocorticoids as anti-inflammatory drugs. Their effects are highly context dependent, especially in the brain. On the left side, we're looking at microglia, the resident immune cells of the central nervous system. When glucocorticoids bind the glucocorticoid receptor in these cells, the receptor can interact with different transcriptional partners, such as STAT5 and NF-kappa B response elements. In this context, glucocorticoid signaling can actually increase expression of certain innate immune receptors, like TLR2. That means that the response is not purely suppressive. It can reshape how microglia sense and respond to stress or injury. On the right side, we see macrophage-like cells which respond differently to the same hormone. Here, glucocorticoid receptor binding to classical GREs increases expression of genes such as P2Y2 receptors or NLRP3, which are involved in immune signaling and inflammasome activation. Again, this reinforces that glucocorticoids are not simply turning inflammation off, but rather reprogramming immune behavior. The key takeaway from this slide is that glucocorticoids are immunomodulatory, not universally anti-inflammatory. The same drug acting through the same receptor can produce different effects, sometimes even opposing effects, depending on the cell type and transcriptional environment and the duration of exposure. This concept helps explain why long-acting, high-potency glucocorticoids like dexamethasone can be effective in acute, life-threatening inflammation, yet problematic when used chronically. In the brain, prolonged or excessive glucocorticoid signaling can contribute to mood changes, sleep disruption, cognitive impairment, and even steroid-induced psychosis. So as we think about glucocorticoid drugs clinically, it's not just about how strongly they bind the receptor, it's about where, how long, and in what biological context the receptor is being activated. This figure pulls together the central theme of this lecture. Glucocorticoids are powerful because they act everywhere, and they're risky for exactly the same reason. At the center is the glucocorticoid receptor activation, which affects immune cells, tissues, and organs throughout the body. The green region at the top of the diagram highlights the therapeutic benefits that we aim for clinically. These include strong anti-inflammatory activity and immunosuppressive effects, reduced blood vessel permeability, and relief from allergic and inflammatory symptoms. This is why drugs like prednisone and dexamethasone are so effective in asthma, autoimmune disease, cerebral edema, and severe COVID-19. But the lower half of the figure reminds us that these benefits are inseparable from systemic side effects. Because glucocorticoid receptors are expressed in muscle, bone, skin, brain, metabolic tissues, and the cardiovascular system, prolonged or high-dose exposures can lead to hyperglycemia, weight gain, and fluid retention, which increases cardiovascular risk. Hypertension, partly through vascular and renal effects, osteoporosis and muscle weakness due to altered protein and calcium metabolism, neuropsychiatric effects, including mood changes and sleep disturbance, and HPA axis suppression, which explains why tapering is essential. Importantly, many of the metabolic side effects shown here, diabetes, abdominal obesity, and hypertension, are the same risk factors that drive cardiovascular disease. So while glucocorticoids can be life-saving in the short term, chronic exposure shifts patients towards long-term cardiometabolic risk. The key takeaways from this slide is that glucocorticoid therapy is always a balance. We accept systemic exposure to control dangerous inflammation, but we must carefully manage dose, duration, and drug choice to minimize harm. This framework also sets up to understand why new strategies aim to separate beneficial anti-inflammatory signaling from harmful metabolic and cardiovascular effects, something that remains a major challenge in drug design. So let's pause and consolidate what we've covered so far. Glucocorticoids exert their effects by binding intracellular nuclear receptors, primarily through the glucocorticoid receptor, and in some tissues, the mineralocorticoid receptor. Once activated, these receptors regulate gene expression, but critically, not in a uniform way. The outcome depends on the cell type, the DNA elements involved, and the transcriptional context. Cortisol serves as the natural reference point for all of this biology. Its structure defines the baseline for receptor binding, activation, and metabolism. From there, medicinal chemistry builds outward. What SAR teaches us is that from very small chemical changes, a double bond or a fluorine atom, a substitution at carbon-16, can dramatically alter potency, receptor selectivity, metabolic stability, and duration of action. This is the conceptual bridge between molecular structure and clinical behavior. Structure determines signaling, and signaling determines outcomes. When we move from theory into practice, the contrast between prednisone and dexamethasone makes the trade-offs clear. Prednisone is a prodrug that relies on enzymatic activation. This makes it flexible and adjustable, which is why it's commonly used for outpatient management of inflammatory diseases like asthma and autoimmune disorders. But that same systemic exposure means that it affects many tissues at once. Dexamethasone, by contrast, is a far more potent, longer acting, and largely independent of metabolic activation. It's chosen when strong, sustained glucocorticoid signaling is needed, for example, in cerebral edema or severe COVID-19. But that power comes with increased risk if misused. Because both drugs suppress endogenous cortisol production, tapering is not optional. Abrupt discontinuation can precipitate adrenal insufficiency due to HPA axis suppression. Finally, the same pathways that make glucocorticoids effective anti-inflammatory agents also drive long-term risks: hyperglycemia, weight gain, hypertension, cardiovascular disease, and neuropsychiatric effects. This central message is this: glucocorticoids are not good or bad drugs. They are powerful tools that demand respect, precision, and context-aware use. And that's where we'll end our discussion of the glucocorticoid steroids.